So I had the pleasure of interviewing Tony, who's a 73-year-old retired engineer from Home with a Supportive Life, who's presented today for an IVIG infusion for chronic allograft nephropathy secondary to BK virus. This is in the background of a long-term type 2 diabetes, complicated with retinopathy and end-stage renal disease for which he has received a renal transplant. His other issues include OSA on CPAP, hypertension that has been pharmacologically managed. His main concern today is with regard to his ongoing health of his transplanted kidney, as he has experienced significant fatigue, fluid overload as a result of his 2 rejection episodes in the last 12 months. I share these concerns in addition to the concern of his deteriorating cardiovascular health and its impact independent for his longevity post-transplant. Additionally, I wonder whether he has undiagnosed pulmonary hypertension as evidenced by his obstructive sleep apnea and tricuspid regurgitation on one exam, both of which are significant contributors to his current independence and level of function. So the first of these issues is this type 2 diabetes. This was diagnosed in 1975 with a oral glucose tolerance test. He denied any symptoms at the time. However, I do note that he's of Indian background. His mother and father both had type 2 diabetes, as well as his 2 sisters. He reports having a very stressful job as an engineer, frequently having to travel and not sticking to a low glucose diet. Throughout his journey, he's never had a continual glucose monitor, and he's unaware of his current HbA1c. He reports measuring his blood sugar level twice each day, one in the morning, which is around 5, and at 10 in midday. He does not report any significant hypoglycemic events, although he does have very good awareness as he gets hungry and develops a tremor. He carries a glucogel during these episodes. At the moment, he is back on his old glycemic medication of metformin 500 milligrams daily, Novamix 20 units in the morning and 30 units in the midday, with good insulin technique with no lipodystrophy. In regard to his type 2 diabetes, his microvascular complications include extensive retinopathy, for which he sees optometrist every 3 months. He's got cataracts in both eyes, as well as proliferative retinopathy, including bleeding in both eyes. He's had multiple cataracts removed, as well as laser surgery, to which he is now currently declared legally blind. He has given up driving as a result of this for the last 10 years. In regards to his macrovascular complications, he's hasn't had a stroke or cardiac attack in the past, nor does he have any peripheral vascular disease or diabetic foot ulcers. I would like to discuss his end-stage renal disease as a separate issue. In regard to his diabetic dysautonomia, he's reported previous falls without significant fractures and no previous gastroparesis. But however, he does report erectile dysfunction, although he was reluctant to reveal how that has affected his mood. He's not had a pancreas transplant in addition to his kidney transplant, and currently he sees an endocrinologist every 6 weeks, as well as a podiatrist every 4 months. He has no special diabetic shoe. He's currently on a low-carb diet, which has been prescribed by his dietitian, and he reports that he has good adherence to this. He reports mainly quoting diabetes as the main factor which caused him to retire early from his job 12 years ago. In relation to his chronic kidney disease, this was diagnosed in 2019 with a routine blood test demonstrating nephrotic range proteinuria. He denies having any renal imaging which demonstrated cysts or renal atrophy, nor any history of chronic kidney disease. His main risk factor for developing this was the poor control of his diabetes. He reports having complications of uremic itch as well as oliguria, both of which symptoms landed him requiring dialysis. He started dialysis at an estimated glomerular filtration rate of 28, 12 months post the diagnosis of his chronic kidney disease, and remained on dialysis for 3 years. He had 2 right-sided, 1 left-sided fistula, as well as a permacath in the interim when one of his fistulas failed. when he attended dialysis, he attended it 3 times a week in a satellite site. Without any complications such as anemia nor needing iron infusions. He denied having any diagnosis of osteoporosis on his recent DEXA scans, although he continues to take vitamin D 1,000 units and calcitriol 25 micrograms daily. He's not currently on a low phosphate protein or a potassium or salt restriction as he's received a transplant, although he reports previously on lanthanum for his dialysis. He's not on a fluid restriction, and he reports his weight has varied between 80 to 93 kilos in the context of his acute rejections. Now I'd like to move on to his kidney transplant. He's had this in December 2024. He received a matched, unrelated cadaver transplant, which he's unsure of the CMV or the Epstein-Barr virus status. He reports overall it was a good match, and he's received this graft to the right side of his abdomen. He's on a baseline dose, graft versus host disease prophylaxis dose of 5 milligrams of prednisolone. And he's unsure of the function of his graft at the moment, not knowing what the creatinine is. However, he has reported 2 previous rejection episodes. First one in 2025, where he presented to the hospital being quite tired with fluid overload, oliguric, where he was pulsed with methylpred. The trigger for that particular rejection episode was to be T-cell mediated, although he wasn't sure how this was confirmed on biopsy or not. The second event of rejection occurred 2 weeks ago, to which he also presented with tiredness and fatigue and was found to have a BK viremia of 1 million. He reports also having a urine PCR done for BK virus, which showed that it was high. Other medications to which he's on for the transplant graft versus host disease include tacrolimus 2 milligrams BD. He's unsure whether this is being currently reduced in the context of the rejection. He reports initially developing tremors when he was started. However, this is settled. He has reported that his hypertension has gotten worse, now sitting in the 150 to 160s range. He's also on mycophenolate 500 milligrams BD with no associated side effects such as diarrhea. In terms of infection prophylaxis, he's on Bactrim Monday, Wednesday, Friday, 160 over 800. He's not on any fungal or viral prophylaxis. In terms of his current steroid regimen, he's on a weaning prednisolone dose of 12 milligrams, and he's due to wean by 4 milligrams weekly until cease. He's also getting intravenous immunoglobulin as a treatment for his acute transplant rejection, to which he's receiving 4 episodes of this infusion as a once-off in the day infusion center. He has follow-up every 3 weeks with his nephrologist, who monitors his kidney in a long-term perspective. In terms of his hypertension, he's on candesartan 16 milligrams, lecandamine, as well as metoprolol 25 milligrams. Although I question whether he's on metoprolol for another reason, as it's not routine in the setting of his postural hypertensions, and he doesn't have atrial fibrillation. He has been vaccinated from his immunosuppression point of view for COVID, flu, and Shingrix. However, he doesn't have any RSV vaccination, and he has had a recent skin check without any skin cancers and a DRE, as well as a colonoscopy performed 12 months ago showing negative for any polyps. He's due for a cystoscopy in 2 weeks for a BK virus biopsy. In terms of his cardiovascular disease status, he reports his mother has died from MI when she was around the age 60. However, he himself hasn't had a myocardial ischemic episode. His current function is around 20 meters on flat ground, and which has been reduced significantly in the context of his transplant. His other risk factors for his cardiovascular disease include poor glycemic control previously, as well as his obstructive sleep apnea, which I'll discuss later. He's had an echocardiogram which demonstrated diastolic dysfunction. To his understanding, he's currently being worked up for amyloidosis. However, he's not had a nuclear imaging or a biopsy. He currently reports having a normal LV function and had had an exercise ECG 8 months ago. He is not on aspirin and does have symptoms of orthopnea and paroxysmal nocturnal dyspnea. In terms of his obstructive sleep apnea, this was diagnosed in 2024 in the context of his obesity as well as daytime somnolence. He's currently on CPAP and has had a respiratory function test in the past, as well as a sleep study confirming this diagnosis. He denies a diagnosis of pulmonary hypertension and is due to see his respiratory physician every 6 months. In terms of his social issues, he's an engineer who's worked in the mechanical engineering field for 50 years. His career was unfortunately cut short and obscured by his chronic medical conditions. His wife is currently the main carer for him, and he has 2 independent adult children. He lives in Werribee in a single-storey house and has received the OT assessment, who have installed a rail and expanded his bathroom to prevent falls. There's no steps entering or exiting his house, and he's financially secure on the NDIS and a superannuation. He doesn't seem to have had a goals of care discussion as well, or a will set up, although he tells me that if he was going to be unwell, his wife would be his medical decision maker. He's currently dependent on a social worker for his personal ADL, such as showering, laundry, given his poor vision as well as his frailty. He does not drive, as I alluded to before, and he has quit smoking 50 years ago and does not drink alcohol. On exam, he's a man of BMI in obese range with a blood pressure of 130 to 160. I did not do a postural as he was getting an infusion. His heart rate was 78, regular rest rate of 20. In terms of diabetic and cardiovascular complications, I did hear an ejection systolic murmur loudest in the tricuspid region, which is consistent with a diagnosis of OSA and possible underlying pulmonary hypertension. He's euvolemic without any signs of heart failure or peripheral overload. There's 2 surgical scars on the right side of his abdomen, one being the right nephrectomy scar, as well as one from a gunshot wound previously. He's got a right permacath scar, as well as 2 right-sided, as well as 1 left-sided fistula, the right-sided being functional at the moment. He has good distal pulses, as well as no sensory neuropathy or diabetic foot ulcers from a diabetic point of view. So in summary, Tony is a 73-year-old retired engineer who used to be an avid world traveller, and his ability to enjoy his life has been severely obscured by his long-term diabetes, as well as his renal transplant, as well as the complications. I have identified 5 issues for discussion. Firstly, the ongoing management of his chronic allograft nephropathy. Secondly, the management of the complications related to his type 2 diabetes, namely retinopathy as well as hypertension. And third, the optimization of his falls risk, vision and autonomic dysfunction being main risk factors. Fourth, the cardiovascular disease prevention, management of dyspnea, given the likely OSA and pulmonary hypertension. And number 5, ensuring future planning that he has adequate goals of care and will discussion.